Okay, now we are live on Facebook, and good afternoon, ladies and gentlemen.
Good afternoon, Mr.
So
Agnes.
we are
Good
live on
afternoon.
Pasito Radio, and I've got those wonderful professionals to talk to us, especially those of us who comes or we are from the Black minority. We all know what is going on during this pandemic. But first of all, I welcome you all to Pasito Radio.
Thank you
Thank you.
for having us.
So today, I will let you introduce yourself.
Okay.
And as I'm sending this to Dr. Arab,
Do you want me to start?
yes, you can start.
Okay, so my name is Araba Hiba Oseikwesi. I am a public health nutrition researcher based at the University of Sheffield. Um, for people who are not too familiar with what public health nutrition is, it is a specialty within public health. So it's based on public health principles. And what a public health nutritionist would do will be things like, anticipating, identifying, characterizing nutritional problems within the population, and also coming up with solutions for these problems. So for me as a researcher, I do research. I do research to try and find out what are the nutrition problems within specific groups. So my focus is on the BME group. What are the nutritional problems within the BME groups? What factors influence these problems, and what can we do to improve their conditions, or what kind of interventions can we come up with? Yeah, just briefly, that's what I do.
Okay. I'll go to Gertrude.
So my name is Gertrude Nsoma Yaba. I'm a social scientist, and my work usually focuses on trying to understand how people conceptualize and understand their illnesses, and how we can find leverage within how people understand an illness, their own conditions, and how we can find pathways or ways in which we can better improve their understanding and use that to help them better take care of their conditions, especially for chronic conditions like hypertension, diabetes, stroke. My work mainly involves trying to understand the social and cultural context and trying to use that to help people understand their conditions better and to be better able to manage their conditions.
Thank you. Then we go to Mr. Buwate.
Thank you. My name is Danny Watson. I am an epidemiologist and an assistant professor of global health at the University Medical Center Utrecht in the Netherlands. My background is a way long back, starting from biomedical science to public health to epidemiology. And then as a researcher, as an epidemiologist, I focus on cardiovascular diseases, which is heart diseases, among migrant populations as well as generally low and middle income country populations, looking at epidemiology, disease burdens, and prevention, and then risk factors. And then recently looking a bit into implementation science, that is how we can translate this evidence that we find in our research into practice. What are the contextual factors that are barriers and facilitators of how we can actualize what we find in research, and then also a bit of maternal health research along the line. Yes.
Okay, thank you. We're going back to, first of all, you people have made me so proud to see my own doing all this research. So a good thumb up to you all for going further at this very stage. Dr. Araba, can you tell us what you have identified
Okay.
through your research among us, the BM group? What
Yeah.
have you really
Right.
identified?
Okay. Yeah. Before I go into that, I just want to just touch on a few reasons why I focus on nutrition as
Okay.
an area of research. So, Auntie Agnes, you know that the research shows that decades of poor eating behavior, so many years of poor eating behavior has resulted in the pandemic of obesity, diabetes, and in other diet-related non-communicable diseases, okay? Now, as always, I always have some statistics I want to start with before I dwell into it. And I know that I can share my screen. So if you don't mind, should I share this, please?
Yeah, that's fine.
Okay, yeah. I just wanted people to see the global picture of the nutritional problems we are facing now, okay? Hopefully this would work fine. Yeah, so yeah, this is from the Global Nutrition Reports 2017. So as of 2017, we had about 2 billion adults who were overweight and obese. Okay, we had 41 million children who were overweight. Now, this is just one aspect of a nutritional problem. We also have micronutrient deficiencies. So when we talk about people who lack vitamins and iron, we had about 2 billion people globally who had problems with micronutrients, people suffering from anemia and other micronutrient deficiencies. We also had a lot of children suffering from stunting, wasting, and that has resulted in a terminology that we call double burden of malnutrition. So globally, we have people, you could have one household where the mother is overweight or obese, and then you have children who are probably stunted or wasted, and then you have adolescents or teenagers who have some micronutrient deficiencies. Okay, sometimes we actually use the word triple burden of malnutrition, so that happens in households, it happens in countries, it happens everywhere. Okay, now, no one is immune to malnutrition. No one is immune to obesity or overweight, okay? But certain people tend to be at higher risk. So people within our communities, we, the BME population, tend to be at higher risk. And so again, I wanted to show some data. This is for children in the reception class. So this is data from the National Child Measurement Program just for the UK. For the year 2014-2015, Auntie Agnes, again, if you look at this diagram, just look at the highest. The Black African population tend to have the highest prevalence. So I'm referring to just children in the reception level. We have, if you take 100 children, you have close to 16 of them being overweight or obese. And compare this to the white British population, it's just 8. So for every 100 children, you have 8 of them being obese for the white population, and then you have almost 16 being obese for the Black population. There's a similar trend for children in year 6. So again, close to 30%. So for every 100 children, 30 of them who were Black tend to be overweight and obese, okay? Now, having said that, we also know that the factors that influences these, like things like overweight and obesity, are numerous. There are several factors, okay? Diet is just one of them, which is my area of interest. And then I'm going to show you why I think, why I decided to focus on nutrition or diet as a factor that influences overweight and obesity, as well as some of the dietary related non-communicable diseases that my colleagues will be talking about. Again, one last figure. So every year, researchers analyze the factors of that leads to mortality, that leads to death. And if you look at this graph here, dietary risk factors is the one that leads. For several years, dietary risk factors results in the highest burden of death globally. Okay, if you look at this, this is deaths in millions. You realize that dietary risk, which includes things like eating too much processed foods, too much sugar, anything to do with diet, the dietary risk factors always are the leading causes of the highest, the deaths that we have globally. So yeah, these are some of the reasons why I decided to focus on nutrition for my research. Okay, so coming back to the main question you asked me, what are some of the findings that I found amongst the Africans that I studied? I did so many things, so I'm just talking about one thing today. I decided to explore the concept of hunger among Black people. I specifically studied Ghanaians in Greater Manchester, okay? And I remember that when I was about to do my research, there were people who were like, oh, but you live in the UK. Why do you want to focus on hunger? Everyone is, abroche, people have money. Why would anyone be hungry? Okay, so the concept of hunger in affluent communities or in high income countries is known as food security. I don't know if it's a word that is common in the media. A lot of people talk about the term food security. Okay, so when we say food security, we are just trying to say that are people having adequate amount of healthy foods? Are people able to get good foods to eat? Okay, so it's not just about the food being available. It's built on 3 principles. The principles are, okay, now I can stop sharing my screen because I just wanted to show those figures. Yeah, so the principles for food security are availability, accessibility, and utilization. The questions we ask are people able to get enough? Is the food available at all in the communities that people live? Are they able to access it? So accessibility has to do with things like, do you have to travel far to get access to healthy foods? Or do you even have the financial means to buy these foods? And then the third concept is utilization. Utilization is when people even have access to these foods, are they able to, do they know how to combine these foods well? Do people understand the concept of healthy eating? Okay, so sometimes the food can be available, but people are not able to access it. The food could be accessible, but people are not able to utilize it the correct way, okay? So once one of these principles is not there, people are said to be food insecure. If you have the food, or if you're not eating healthy foods, or you're not utilizing it well, then you are food insecure. Okay, so this is what I did within the Ghanaian community in Greater Manchester. So I went around, I interviewed lots of people, I explained the concepts to them, and I'm like, do you think, looking at your current situation, do you think you are food secure? And interestingly, generally, most people did say that, you know, after they understood the concept, most of them said, oh yes, we think we are okay. We get enough of food to eat, you know, and it's because they were comparing it to Ghana, and the fact that in Ghana, there were certain areas where sometimes, you know, the people are not able to access food and things like that. So they agree that here, no matter what, you get food to eat. Now, the issue had to do with healthy foods. Okay, so some of them were like, someone actually used a terminology known as belly food. If you want to eat, you know, no matter what, you get food to eat. But the concept of food security is not just about filling your tummy, okay? So this is where we had a problem. There were people who were like, okay, due to, and I always, whenever I have a chance to talk, I talk about this. There were some factors that I identified. They were like, due to the fact that we have several commitments and we have several responsibilities, food is not a priority for us, okay? We eat, yes, but we don't go out of our way to go and buy all these. It is expensive, and I don't have the data here to show, but I can still remember that if you want to follow the government guidelines on healthy eating in this country, research has shown that for people, low income earners, that is about 70% of your salary. Now you tell me, how many of us would spend 70% of our salary just on food, given that we have so many other commitments, okay? So that was one of the things that came up from my research, that people don't eat healthy foods because they need to remit home. They have responsibility of building, you know, they need to build property for when they go back to Ghana. Also, people who had just arrived in the UK and were trying to still working on their visa status, and, you know, who were unemployed, were also some of the people who were within, who tend to be at risk of food insecurity. Now, another reason why I focused on food insecurity is that research has shown that there is a link between food insecurity and these diet-related non-communicable diseases. You know, when people are food insecure, they tend to be at risk of, you know, overweight and obesity. They tend to be at risk of diabetes and hypertension. Do you still want me to go on? Or would you want to go around and come back to me?
We'll go around and come back again. So I'll jump to Gertrude.
All right, okay. Gertrude, we can't hear you.
Yeah.
Sorry, I muted it when Hiba was talking to avoid the noise. So my thesis, actually my PhD thesis focuses on trying to understand, identify and understand why people have Ghanaians, migrants and living in Europe in particular, have a poor control of hypertension, which is a major risk factor for cardiovascular disease. This is important because despite many more Ghanaians getting diagnosed as having hypertension and or having diabetes, many more people are becoming aware and we are getting access to treatment for these conditions, yet we are not able to adequately control our BP or diet. This is important because conditions such as hypertension make it easy to develop more chronic conditions like stroke. And particularly now in the era of COVID, it makes it easy for us to contract and die from COVID because our body's immune system is weakened fighting these conditions. Now, so my thesis looks at this particular topic from a range of factors. For today, I will focus on the individual and the social factors. So we all know that we are supposed to be, if you are diagnosed as hypertensive or diabetic, you're supposed to be taking your medicines. You're also supposed to adhere to certain important recommendations regarding diet, exercise, tobacco, and alcohol control. Now, what I try to do is look at what are the social and cultural values that make it easy for us or make it difficult for us to adhere to these conditions, these behavioral conditions, and also adhere to medication, taking your medication. Now, in one of my studies, we found that people are aware that they have the condition. People are aware they go for the treatment, but they don't take the medications, particularly for men. One of the key reasons is the fear of this growing weak sexually or having erectile dysfunction, or even for women, it's just like, I have to go to the bathroom all the time. I have to urinate more frequently. I cannot be taking the medicine for the rest of my life. So the whole concept of a disease that is long-term, it's absent in our psyche. And that's also because in the past, we had, we were going to farms, we were eating fresh foods, we were eating like foods without Maggi, so too much salt. Everything was predominantly more natural. So it was easy for us not to have these conditions because there was the absence of urban issues. Aside that, also, medically, when people died unexpectedly, which was rare, it was witchcraft or whatever. But now we have all these biomedical facilities, which are much more, make it easy for us to diagnose these conditions. So that's why we have such a high prevalence. Like in the whole world, Africans have almost 50% risk of nearly 50% of Africans have hypertension. It's 46% as of 2008, but as of now, you'll be hitting about 50. Now, the key issues surrounding these conditions, the diagnosing, is one of the key problems. One of the key interventions that we consider a problem, because you have to take the medications to be able to adequately control the condition. However, because of these perceived side effects, such as the sexual weakness, people take alternative treatments. And these alternative treatments have a potential to make your condition worse, especially for men, because of the fact that, we consider men who cannot, in general, you would say a man is a weak man if he cannot perform well sexually, and all the so those kinds of social issues are there. And
you
so
many that's amazing.
So those kinds of social issues are there. And traditionally, we take things like bitter cola, cola nuts, we take all these herbal remedies that are supposed to boost the immune system. Now, currently, there's no scientific evidence that taking these remedies or bitter cola in particular can cure you or much more help you control your hypertension. It is because bitter cola is an caffeine-producing nut. And so it has traditionally been used for a lot of illnesses and as a sexual stimulant and aphrodisiac. So it increases the drive. It also increases your stigma. And so many men who take this feel that it is able to control their hypertension and also help them to have, sex with their partners. And because of that, they would much rather take bitter cola than take their medications. But the reality is you only continue to weaken your body's immune system until we have sufficient evidence that bitter cola does, contribute to some extent to, managing your hypertension. This is not a good idea to go by. So that's one of the key findings. The other one that you can look at the individual level is the issue of, food is tasteless. What is tasteless? Without salt, we are used to eating food with salt. I mean, even traditionally in the past, in our rural communities, when we want to dry food, when we want to preserve food, what do we use? We use ashes or salt to preserve food. So our psyche and our entire concept of salt consumption is structured around all these cultural norms. And as Hiba has talked about food insecurity, for instance, I come from northern Ghana. We only have one rainy season. And it's only 3 months of rainy season. You have to preserve food. Otherwise, the rest of the season, you will die or you will starve. So people are used to the concept of eating salt, a lot of salt in their food. Now you need to control salt intake to be able to...
That's, the Kobe and the beef.
Exactly. So we need to be able to control this salt intake in order to enhance our body's ability to effectively manage hypertension or work with the medicines that we are taking to manage hypertension. Even when we try to implement these changes in terms of salt reduction strategies, even when you do try to implement it, most of the times what do? We separate that person's food from the rest of the family. Now, hypertension does not work like that. It is a chronic disease, but it's also partly genetic. So you increase your own risk if, for instance, my uncle had hypertension. That's one of the main reasons why I did my PhD in hypertension. We separated his food and cooked his food separately. But the reality is that because we are his offspring, all his children have an increased risk of getting hypertension. The chances of them getting hypertension is high. And so when one person has a chronic illness, it is important to recognize that there are genetic factors. And so whatever modifications that we implement for that one person must be implemented for all. Of course, we will not be taking antihypertensive medication and such, but it is important that we reduce our salt consumption. Also, if you look at the issue of exercise, it is not something that we do. In fact, in one of the interviews I did, one man asked me, how can I just get up and be running around in this hot sun? Another told me, if I'm even running around, people will think I'm crazy. And these are the realities of trying to have behavioral modifications at that level. And so people need to understand that it is not just about running around aimlessly. It's about, finding ways of doing group activities that exert a lot of energy. For instance, we used to go to the farm. There was a lot of work being done. So we had, technically, we were keeping active. We used to walk long distances, which is almost, it goes very well in terms of running. But now we don't do those things. We used to dance a lot, cultural festivals and all that, we would dance and all that. All that helped to keep our bodies in shape and prevent obesity, which is also a risk factor. So now we don't do all those things. It makes it easy for us to have these conditions, and it makes it much more difficult for us to control. Now, on the flip side, those traditional practices also in a way contribute to the reasons why we are unable to control our hypertension. For instance, if you go to a naming ceremony and they do the name, when they are doing the naming, what do they use? It's not alcohol. The food that is being prepared, are they going to say, oh, because some people are hypertensive, we are not going to have a lot of salt in the food? So Maggi and all those things are all going to be present. So those social norms, until we can all come together as a people, understand that our risk, and for instance, hypertension is much more common among Black people, and it is much more difficult to treat among Black people than any other race. So until we come together to understand that one person's health affects all of us, and particularly for us in Ghana or among Ghanaians, if your father is sick, the whole nuclear family is sick. Your entire extended family is sick because we are not individualistic to that extent. So all of you are going to contribute financially and moral support, social support, all that you're going to contribute at various levels. So that one person's chronic disease can make us even much more poorer than we originally were. And
okay, so if I listen to Gertrude, all you are saying is about our mindset.
it's about social
More about
value.
our mindset to understand what is going on around us.
Yes, and also it's not just the mindset, it's also a recognition of among ourselves of how our situation, what our risk is, one, and how our social and cultural practices contribute to these. I mean, culture is beautiful, culture is rich. It is supposed to be preserved, but there are certain aspects of culture that need to be adapted. And for instance, if you go to like traditional homes, especially homes where you have families living together, especially if it is a woman who is hypertensive, are you going to say because this one woman is hypertensive, the whole family should not eat salt? You are most likely going to lose your husband if you're going. In fact, in one of the interviews I did in the North, the woman said her husband has 3 wives, including her. And when it's her turn to cook, the husband complains that her food is tasteless. Is she going to stop cooking salt for the husband and the
To leave her? No.
Exactly. So there are so there are a whole lot of reasons why people behave the way that they behave, and it's not necessarily because they don't know that it is at a high risk for their condition, but their social structures that make it difficult. We ourselves have created those structures that make it difficult to improve upon our health, and it is very important. It is very important that we recognize that there are varied differences in how we handle these situations, and also the fact that we create these social structures, and so we must find alternative ways where we can enhance those social structures, not destroy them, because they are a part of our identity. So
I realize Gertrude, you've got a lot. Let's go to Mr. Boate and I'll go round again. No, I'll go around. You're making a good point there, because it's time for us to know that there is changes in life, and we ourselves, we need to change. That's what I was talking about, mindset. If our mindset tells us that this is what is happening, so we should change our lifestyle, it will help all of us. So I'll go to Mr. Boate.
Thank you very much, Auntie Agnes. I think Gertrude has a lot of interesting findings to share. And then most of the things that she found obviously correlate with what we also found in the studies that we did among migrant and population from sub-Saharan Africa. I focus on cardiovascular diseases, though previously I've done some work on hypertension, knowledge and all that. And we know that cardiovascular diseases such as stroke and heart attack are the leading cause of death globally, with about 17.6 million deaths as of 2016. The burden is higher in populations of low and middle income countries, where we come from. And then that is what makes it a major concern for us to look at what is causing this high burden of disease among populations from LMICs. And then also as Sub-Saharan Africans, having our own background in LMICs, being migrated to Europe, we know that we came with certain characteristics from our background. And also we are going to acquire new characteristics as we live in a different country. So where were we born? Where were we raised? And now we've moved to Europe, an urbanized setting. And we know that cardiovascular diseases are affected by rapid urbanization, urban poverty, and then globalization. So definitely there's the need for us to look at, once people have moved from Africa to live in Europe or to live in America for whatever reasons, the BME population, there's the need to look at what are the factors that are contributing to their health. And we know that all these factors that have already been raised by Hiba and Gertrude, being diet, being knowledge, being perception, we need to understand how these differ from our people who live back home, for us to be able to understand that how is the living in an urbanized environment contributing to our health as migrants. So my research was mainly looking at the differences now as we live as migrants compared to our home country populations, and trying to be able to quantify the burden that migration is impacting on our health as a people. What did I find? Basically, the findings of my study was that there's high risk of cardiovascular disease among migrants. And before that, the studies have already shown that even when it comes to cardiovascular disease, there's a need for us to distinguish between the source that a migrant is coming from. Because, for instance, stroke is higher among Sub-Saharan Africans and the Southeast Asian migrant. But on the other hand, coronary heart disease is more common among South Asians, but less common among Sub-Saharan African migrants and then North African migrants. So we need to understand which aspect of cardiovascular disease is affecting our people, because the risk factors of cardiovascular disease are more predominant with a certain cardiovascular disease than the others. Salt, diet, how does this affect a specific cardiovascular disease? So we need to understand all these differences. But generally, focusing on where we are coming from, Sub-Saharan African, we realize that our burden is higher than those who are living in Ghana, those who are living in urban Ghana, those who are living in rural Ghana. And then even if you take the same population of Sub-Saharan Africa, for instance, if you take Ghanaians residing in different countries in Europe, residing in Netherlands or Germany or the United Kingdom, the risk is different among these people. So what is happening? Is there any role of context? Do we pick certain lifestyles where, so Gertrude spoke about a collective social norms. So is it that Ghanaians living in Amsterdam are doing something peculiar to them? Is there a lifestyle that is common among the community, which is different from Ghanaians living in UK? What sort of foods are there, as Hiba explained, that Ghanaians buy in the UK that is not in Amsterdam? So what are we exposed to? What's the food environment? What is the cost of food in all these environments? What do we eat whilst we live in different contexts? And all these needs to be explored for us to understand specifically what is happening to our people as we've migrated from Ghana or from any other African country or from any other LMICs to live in an urbanized city in Europe or America. We also realize that there's this perception of discrimination. So we Africans really perceive that we are being discriminated against in our jobs, in our homes, and this perception put some sort of stress on us, and that also influences our risk of having a cardiovascular disease in the long term. And then recently there's been a new research focus into what we call our developmental origins. And then I think Gertrude mentioned something about genes, genetic predisposition. There's this focus on where were we born, where were we raised, what were our conditions. And we realized that people who were from impoverished socioeconomic backgrounds are more exposed to cardiovascular disease when they grow. And we know that most Ghanaians who are living in Europe or who have traveled or migrated probably might have had such poorer backgrounds when they were young. So how is this translating to their risk of diseases whilst they are old now? And then we know, for instance, now we have a major condition in our hands, a major outbreak, COVID-19. We know that underlying conditions have a role to play. And we hear in the news that Blacks in the UK are more likely to die. Probably they have more underlying conditions because we know diabetes and cardiovascular disease, heart diseases. If you have these conditions, you are more likely to die. So we have to be able to understand and quantify how many of our people, what is the, and I think Catherine mentioned that almost about 50% of the Black population are hypertensive. And if this is true, then it's probably so a reason why we are more likely to die from the current COVID-19, because we all have underlying conditions that have effect on our hearts. There's more diabetes, because what was done in Netherlands, for instance, showed that the Black population is more affected by this disease than the Dutch population. And I know it will not be so different from the population in the UK. So we need to really look at these factors, though we have explored some. We've come up with diet, stress, physical activity, smoking, very much important. And one thing I realized was that people, when they migrate, begin to smoke. People who were not smoking whilst they were in Ghana, they tend to smoke when they migrate. I don't know whether it's a societal norm and most of them blame it on pressure, blame it on difficulties of living abroad. But we know smoking has a lot of effect on our heart, cardiovascular diseases, hypertension, diabetes, and all that. And if someone smokes, the person is more likely to die of COVID-19. That's the truth. That's the reality. So we still need to assess further, looking at all these risk factors and be able to understand what is really happening to our people. So if there's a broad question like what is the health of migrants, as far as the heart is concerned, I would say not so good. We are not doing everything right. though we have some things. There's one quotation that I always quote from Heber's research that Ghanaians in the UK still adhere to the traditional diet whilst adopting some aspect of the
Can
UK
you
food
repeat
culture.
that for
It's a
us,
very
please?
strong
When you
statement.
got to the
So even
point,
though we
you had
try
a break, a little break. Can you repeat the research you were saying? Because there was a break, so we didn't really hear it clearly.
Okay. From Heber's research.
Yes, please.
Yeah. So there was a find in the conclusion in her research, and it says that Ghanaians in the UK still maintain the traditional foods in Ghana whilst adapting to some aspect of the UK food culture. But the question is, what aspect are they adapting in? What foods from Ghana are they keeping? What portions are they eating? What quantities? There was a video on social media where a Ghanaian from US said, had the onya bibia maybe Vietnam, and then there was a big fufu with
the whole food,
plenty
yeah.
meat. Yes, and that's how we eat because now we have money. But let's ask ourselves, how does it impact on our health? So that's the kind of things that we are dealing with, and the need for us to be able to explore. And I think I'll leave it here for us to go to the next round of questions as time.
I'll go back to Dr.
Right.
Araba to try and continue where she
left. You want me to continue? Okay.
Yeah, so I'll go back to Gertrude again.
Right. Okay. So I realized you were asking earlier on that is it a mindset? Yes. Yeah. The mindset is just one of the factors. Okay. And I always like to mention that when we are discussing these things, the risk associated with obesity on these diet-related conditions, we are not fat shaming anyone. Okay. Yeah. We've moved, public health has moved beyond that idea in the past where we used to victimize people. So when we say people are fat because they just eat unhealthy foods, we've moved beyond that thinking. Research has shown that for nutrition, people living on low income consume unhealthy diet, not just through ignorance or irresponsibility, but in response to the social, cultural, and economic circumstances. Okay, so I'm not in any way saying that people are eating unhealthy just because they are irresponsible or they don't know. When I went around doing my research, there were some Ghanaian women who told me that, all this talk about eat 5 a day and healthy eating, tell me who doesn't know? People know. It's on the internet. People are aware of the importance of eating healthy, but they eat the way they eat in response to their social, their cultural, and economic circumstances. And in public health, we call that the social determinants of health. There are so many of them. One of the issues is that within the BME population, for so many years, you realize that a lot of us tend to be we are not a homogeneous population, I know that, but a lot of us tend to be poorer than the other ethnic minority groups. Yeah, even as compared to the Asians, we tend to do menial jobs that don't pay so much. And all these things, because income and finance, your level of education, all these things influence our factors that influences our health. Okay, I wanted to show that graph that I talked about, because I always think it's important to, okay, even if I can still explain it. So this is a cost of nutritious diet in the UK. And this was just done in 2018 by the Food Foundation. So for people who earn 70K and above, if they wanted to eat healthy, follow the UK dietary guidelines, it's only about 6% of their income that will go into trying to maintain a healthy diet. For people who earn 11,000 and below, it's 74% of their income if you want to eat healthy. Similarly, it goes on like that. So there's a trend, and for people who earn, let me use an average, maybe 15 to 20, that is still about 20% of our income. I'm showing this because this has implications for us as a community, because I know it's only a few people within our community who would earn like 70K and above. Okay, so we know the dietary guidelines exist. We know that we need to eat healthy, but our priorities as a community, we tend to point fingers. We know that it's not necessarily it's as a result of our economic situation. But so what are we going to do about it, Sister Agnes? we don't earn much. Are we going to sit down and wait for the government to come and give us vouchers to buy healthy foods before we eat healthy? I'm saying two things here. I'm not blaming us as per se that it's because of our irresponsibility, because the research shows that other factors that's influence, like the cost of nutritious foods. But so what are we going to do about it? Okay, so in subsequent sessions, I might talk about some suggestions on what we can do still with our income. We have to empower ourselves. Definitely, we have to move on in life and try to improve our economic situation. I know there are people who are advocates trying to speak for us. I know the CAN and other groups are trying to make our lives better for us, trying to lobby with the government to improve the lives of Black people. But we also need to do our bit. We need to do our bit, okay? Yeah. I'll stop here. I want my colleagues to also chip in, and then we can
go. Okay, we'll go back to Gertrude.
Yeah.
Well, I specifically want to talk more about the traditional remedy use, because I think that is where the bulk of our problem is. Nobody says that there's no benefit to traditional herbs and remedies. We are just saying that because you cannot isolate the specific components that are needed to enhance your health, it is better to follow the recommended ones. So for instance, in Ghana, you have the traditional medicines and traditional and alternative medicine use. And this organization is within the Ministry of Health, and it tries to regulate herbal medicines. The idea is for them to certify herbal medicines, and also together with the National Media Commission, encourage certain particular traditional herbal medicine use. So there is research going on to try to find effective herbal remedies, especially for those who have issues, taking chemicals. But the reality is even the chemicals come from the herbs and the plants. So the idea is not that the herbal medicine is bad. We are just saying that because you can't isolate the specific element needed to enhance your control, the other elements that are inside the herb, because the herb is not made up of one component. So because of these other components, you don't know the effects on your other aspects of your health. This is what makes traditional herbal medicine use dangerous. So right now, we have medical herbalists who are trained from the University of Science and Technology, and they consult at regional hospitals in Ghana. Now, these ones are the ones that can potentially recommend good herbal medications that can aid your hypertension or diabetes or whatever. But the issue is there is no treatment as of yet that can effectively cure hypertension. We need to establish that chronicity in our heads, that you are going to be on medication until we find a cure. And so people should, and medicine has evolved. I mean, in the past, you had all these issues about side effects and all that. People continuously improve upon these medications, working on these side effects to try to enhance your health. So right now, if you go to a health facility, if you're hypertensive and you go to your GP or you go to your health facility, the best use of your time would be talk to your GP. These are the foods that I traditionally eat during the week. Of course, we as Ghanaians, we don't do breakfast, lunch, and supper. Sometimes you do mid-breakfast, mid-lunch, mid-supper, late supper, those kinds of things. So you just specify the kinds of foods that you eat and let the GP work with you to find the best possible combinations and quantities that you can, consume in terms of diet. In terms of exercise, talk with your GP. Let him or her understand what your daily routine looks like and how he or she can help you build in. Because if you don't take control of the situation, it is your health. And at home, social support is very, very important. Now, I recognize that because of our economic conditions when we are migrants here, it is very difficult for most of us. Some of us work 2-3 jobs. So you are not always there to even, adequately prepare good food for the person. But you should be able to, store food. You should be able to plan in advance what kinds of foods should be available. Of course, I'm also someone who does not eat like planned diets, but I make sure that I have the various types of foods I need in my fridge. So as and when I feel like, let's say, eating fufu, I pick my fufu. I know the kinds of soup I want, and I know how I'm going to plan myself within the week to be able to keep to that diet. And also exercise. We need to change our mindset, and we need to understand that one person's health affects the whole of the family, and that family affects the whole of the community. So we together must work to be able to encourage adherence to these behavioral
Somebody is
modifications.
saying that he wished, he's a social worker, I know, he said he wished this conversation can also go down to our local dialect for some people to be able to understand it very well. Because some people will be listening, but it doesn't really. Yes, so she said, because I remember I did a program with him. We end up speaking aware. We did Fanti that time with Ghana diaspora women. So I think it's a good idea as well that if you get to a point, whoever, because we had aware, we had Ghana, we have the tree that day, and it was amazing. So he's saying that can we, in a point, that summarize this thing again in our dialogue, because we are talking to Ghanaians as well, and some of them, what we are saying,
I mean, it's really difficult sometimes explaining what hypertension is. Talking of hypertension specifically, even the translation of it in our local
but you know, one thing is, most of the time, Gertrude, we know, we heard about it. The person who knows that hypertension is a sickness. So with the names, we know most of it. If it doesn't go to school, you know something is called this.
Mm-hmm.
Even we don't know the name. I know BP. We say Mojamoroswo.
Yeah.
That day I went to Ghana and somebody said, "Oh, when him say sugar," I thought he was selling sugar.
No, diabetes.
So I said, I said, "We're in a Juma Watamo or sugar factory now." So there be any. I realized the person was talking about
true.
Diabetes.
It's important. It's important that we are able to provide
about the mother who has got diabetes. But I said, I thought maybe he wanted even sugar from me.
I think it's one of the key findings that we have common in all our studies, is that whatever important information, research findings we have, and how we can translate this into practice, it needs to go into the local dialects. Okay. Now, it's always very difficult for me speaking Tree, because I don't speak Tree so well.
No, we don't need you to speak. We want you to speak your dialect.
Yes,
that's what we did.
I'm coming to that.
You to speak your dialect so that whoever is listening from your side will understand as well.
Yes, that is very important. But yeah.
You know, we have this professional network, a few of us, and to be honest, it's something that I was thinking about. We'll take it on board, because we are we have Nigerians, people from Eastern Africa, you know, and we want to, because for a long time, a lot of the work we do ends up on shelves. We go for conferences all over the world and present to other researchers, and the people who really need our findings, we leave them out. So that's what our network is also trying to do. We now want to start engaging with the community. So we'll try and use a local language. I mean, even if it's not on a radio program, we started with one video that we did. We'll try and use a local language for different, you know, African countries, so that we have a wider reach. You know, it's something that we would consider. And then when we talk, you know, we would chip in some.
When I was speaking, I actually said something in my local dialect. I was like, the man said, how is he supposed to keep his wife happy if he takes this medicine? But that is my local dialect, and I'm very sure very few people would speak it. So it's always difficult to speak and then explain again in English. So yeah, but I think it's the way to go. It's one of the key findings in at least in my thesis, is that whatever information we have, we need to translate it into our local languages, and it has to be apt information, correct translation of the information in such a way that people can understand. Of course, if we are talking diagnosis and prevalence and what people would not understand that.
So
simpler language of instruction in our local dialects.
Daniel. Oh,
Daniel.
Get it finished now.
Yeah, I'm done.
Yeah.
Okay, we'll go back to Mr. Boateng.
Yes, thank you. So I think my two colleagues have already covered most of the important aspects. I think there's a lot of information we've given out today. I'll just add one or two to allow the listeners to be able to decompose what we've put out there. I think translation is very key. And that is one aspect of implementation science now that we're looking at. How do we get the people to benefit from what we did and what we found? And that's why we think this program in its first place is very key, very important. Because our books are sitting on the shelves. We're still doing more research now, and most of them find themselves in the journals where nobody goes. Ever told me that I tweeted my research and only Daniel liked it. So it's interesting. It's interesting how they try to make impact, and then it doesn't go anywhere. But I think through this medium we can get people, because as I said earlier, the factors that influence our health are peculiar to us. That's what we have to understand. Even among the same cluster of conditions, the ones that affect, we did a study on multimorbidity, looking at conditions that affect Ghanaians, and we realized that the set of chronic conditions that affect Ghanaians in Amsterdam is different from the ones that affect Ghanaians in Accra, or for instance, in a village in Ghana. So even when it comes to what conditions are affecting us, it's different depending on where we live. So we need to really understand what is happening in our context. Context, they said, is key. It's not key, but it's key actually. So we need to understand that to be able to tailor that to the health of our people. Our origins, where we are coming from, I've said this earlier on. Did we migrate from a rural setting? Did we migrate from an urban setting? We need to look at that, because that could have an impact, because there's something we call epigenetics. So the genetic conditions that we're predisposed to, and then how that interfere, or how that expresses itself in our current environment is also very key, and that is going to determine what conditions. So to wrap this up, I'll keep on advising Ghanaians and the Black people in general. Gertrude made a lot of issues about adherence to medications. Please, let's adhere to what they've given us as medical doctors. If we don't understand anything, let's go back to them and ask them. We don't necessarily switch from one medication to another, because now when you do the cascade of care, you realize that control of hypertension and diabetes is very, very poor among Blacks, very, very poor. And how can we move forward if we are not able to control our current condition? It's mostly because we switch medications to herbal medicines without any recommendation from our house doctors or our medical. And then physical activity, we try. I never cycled when I was in Ghana, but I cycle when I'm now in Amsterdam. I cycle a lot. So let's make good use of the opportunities that are given us in our new environment. Smoking, we try as much as possible to desist from it. There was a study which showed that people who smoke don't think smoke affects their health. Smoking affects their health. That is very key. So probably they don't really understand the impact of smoking on their health. They think it alleviates their stress, because the stress is more key to them. They think stress affects them more. So if smoking is going to take away their stress, they rather smoke, because if they are stressed, they'll get BP. So these perceptions, we need to work on them. And then alcohol intake, our social gatherings, how do we minimize these food intake, alcohol, and all that? These are key points that I'll leave with. And then once we try to live healthy, I think we can be able to mitigate most of these factors that affect our health. Thank you.
Okay, thank you, Mr. Boateng. Yeah, can you see a can we custom when you know tough and say. Study a backray a fast swab in Lumia, a best shay a pong with him ye, a cry a fast way a bit dear papa. Yan jai say, yet Japadi, and I hear if you say Yanka say any peduana ye Japadia cassia. A what's a year war. It's a normal camo jam, so was or a car stroke, blood pressure mojamosro esichire yare edru ya kan nyina ho asem ye nhwe ye duane a ye di emujie ti asem na ye kan na ye introduction e na omo ba be ye nyame ya abon obesa ba ni aba se bia ye fa topic bi se bia high blood pressure high cholesterol diabetes ni nyina no ye be ye no kakra enti wanti bibia kra na bia wotene se hwe waduane mu yie waduane mu a wudi ni hwede ko wo mu no eyie na watena ase ache eduro so aye dia ma wo no so yesi bomode ya na yede nanom the doctor mfa bibiduro ma wo a na okofa no ma ebi kura na ene ne awo no mo na mo ebra na kofa nsoso aso e de amaye tende ye shia Dr. Araba na Dr. Boateng na Dr. Gertrude so enne nyame ye shira ye fefefe ama ye nya ye nuane mi mo kyerɛkyerɛ efi se wo be ba so abekyerɛkyerɛ kakra na wo be hwia se ne ye be ya kasa ne ye be hunya bebre ne ye de aba. Dr. Araba, what do you have to say to conclude?
So yeah, just to conclude, and one wakano, but three things from FAO COVID-19 FAO HIA message say HUES on my acronym. H stands for healthy eating, and on our kind. In Rona Kano, you cannot, if you're not eating well and you take those medication, it will not work. So healthy diet, as you know, is important, even if you're taking the medication. Exercise, I had something I want. So I have, my brother is very, very skinny and he likes to keep fit. He was jogging once in Ghana and someone called him and said, "Gentleman, come here. Why are you exercising?" So, that mindset say, if you are not fat or big, that anytime I remember that, the man was so concerned, say, why, Michelle, we need to change that mindset. So exercise, Gertrude has already touched on that. Water, juice, fruit juice, too much, sweet drinks. A lot of us, because we feel like back in Ghana, the drinks, the drinks are too much. And sleep. I can't overemphasize that enough. 2-3 jobs. We want to build properties in Ghana and we want to, build mansions. We will not live to go and stay in those mansions if we don't sleep, if we don't take time off work to rest. It's a message from FAO, not from me, Hughes. Finally, the time to invest in our nutrition. If we are not doing it already, this is the time. We need to invest in our nutrition. It forms the foundation of our health. Madam Wase, thank you. Thanks, Sister Agnes, for having us.
Thank you so much, Gertrude, Mr. Boateng. I know this is not the last time we're trying to help. In Pasito Radio, all we do is educational programs to help the community. So please, I know I will show you the time that they will come on again. We'll do the advert, you know the time they will come. But if you didn't hear anything, it's a save yourself in what you eat. Love yourself. We do MOT for our cars. What about the body? We don't. So please let us help ourselves. I always say that if you pile the money and at the end you have the sickness, you don't even enjoy it. Because you can't even put on the clothes if you have to go and do chemotherapy. You don't even have time anymore. You don't enjoy it. But let us enjoy the fruit, the work, the hard work. So during our pension time, we can enjoy it. Thank you so much for coming on.
Thank you for having us, and thank you, listeners.
Thank you.
Thank you so much.
Please share the video, educate somebody. This is the important video. You will save somebody's life by sharing. God bless you all.
God bless you too.